Implant dentistry is undergoing some amazing transformations today. With the help of CT diagnosis and digital treatment planning, general dentists can predictably surgically place and restore many different designs of dental implants to improve the quality of life of their patients. Innovations in design and materials have made our job as clinicians less complicated and more successful than ever before. Implant dentistry has entered into the mainstream mindset as well, with many patients asking about the benefits of dental implants. However, we sometimes are presented with challenges relating to bone quality or quantity, anatomic restraints, and aesthetic complications. The therapeutic goal of implant dentistry is simply oral rehabilitation and improved form and function. When we include dental implants in our diagnostic armamentarium, we provide patients with hope for long-term positive results. Modern technology and design enables us to surgically place implants in compromised areas. Our first slides today demonstrate the facial and lateral views of a 64-year-old white female who has been edentulous for more than 25 years. Figure 4 demonstrates her conventional maxillary complete denture, and it was certainly retentive and provided enough lip support for proper aesthetics, but her conventional mandibular complete denture was never completely stable and dramatically diminished her perceived quality of life. It just moved around and was a real problem. Figure 5 and 6 and 7 demonstrate proper lip position with a properly formed conventional denture. Figure 8 in this situation shows the preoperative bone morphology in a two-dimensional radiograph. Clinically, there appears to be a thin mandibular ridge. However, if we do take a CT scan or a three-dimensional image, we can see that there is indeed enough cortical width of bone, anatomic width, and height of bone to possibly place some dental implants. CT diagnosis allows us to visualize the patient's available bone in 3 dimensions and to even virtually place the implants prior to any surgical intervention with the patient. CT scanning is fast becoming an important tool in the diagnosis and treatment of dental implant position and placement, especially in areas of the mouth where bone contours are difficult to determine with conventional radiographs or simple oral palpation. CT scanning softwares allows for the determination of bone quantity and potentially quality. For the less experienced clinician, this tool also helps determine potential risks involved in surgical placement. Correct position in bone and angulation are determined prior to any surgical intervention. CT planning software also helps to eliminate potential manual placement errors and can match the surgical planning to the eventual prosthetic reconstruction. Finally, the software allows for surgery to be less invasive and more predictable because there is no longer a need for a full thickness flap. Instead, the implants are placed using a flapless approach, which we will demonstrate in this program. Figure 10 demonstrates simple anesthesia to the area. We are simply infiltrating the surgical site. We are not doing any mandibular blocks, so the patient's tongue will not be numb, the patient's lip will not be numb. We're really just anesthetizing the soft tissue over the bone. Bone is not necessarily innervated, nerves run through bone, so we have a safety device in that if we are close to any significant anatomy, such as the mental foramen, the patient will be able to respond to us and we can change our position. We'd like to demonstrate the three-dimensional view of the CAT scan, which reveals a relatively short, wide ridge with a thick cortical plate. Utilizing the patient's existing denture, we were able to plan the case from a surgical and a prosthetic perspective. In our situation here, we decided to place 4 3-millimeter implants in the symphysis area. The CT demonstrates that the implants were angled slightly to the labial to maximize the length, thus establishing bicortical stabilization and locating of the O-ball head of the implants under the anterior teeth of the denture, which will be demonstrated as we move a little further. Figure 12 and 13 shows the surgical guide and directional sleeves for a very narrow diameter pilot drill. This was fabricated as a duplication of the patient's existing conventional mandibular denture. But you have to remember that that conventional denture has to be well-fitting and stable prior to fabrication of any surgical guide. The following figures demonstrate the use of a small diameter pilot drill, which was used through the sleeves of the surgical guide to create proper angulation and position of the 4 small diameter implants. Perforations were made through the soft tissue and through the crestal portion of the cortical ridge. This allowed for directional placement of the implants. Figure 17 shows how the tissue and cortical bone were perforated, which will allow us to directionally place our implants quite effectively and easily. Remember, this is a flapless procedure, so it's very, very atraumatic to the patient as opposed to a full thickness flap. The directional guide is removed, and in figure 18, we show a 1.8 millimeter drill used to depth as determined by the analysis of the CT planning software. So the CT planning software allowed us to virtually place the implants prior to any surgical intervention and gave us the length of implant that we want to use. And the surgical guide allowed us to directionally place the implant in the proper position. The directional openings were used to correctly angle the drills to the predetermined depths, and that was 14 millimeters for the number 23 and 25 implant areas, and 12 millimeters for the 22 and 27 implant areas. Figure 20 demonstrates the use of a radiograph, or a digital radiograph, which was taken to ensure proper depth. When we know that we have proper depth in determination of bone density and the height of the tissue, a 2.4 millimeter drill is then used to the predetermined depth to create the osteotomy site for the final 3 millimeter mini implant. Because these are self-tapping implants, there's no need to use a thread former. The bone was dense, but not that dense. The final drill used to form the osteotomy is side cutting only. The pilot drill alone determines the depth of the implant placement, and there's no intermediate sized drills used in this technique. Figure 24 demonstrates the final osteotomy site through the tissue. The 3.0 mini Oko implant is then hand tightened to establish initial stability. Then a torque ratchet is used to thread the implant to the desired depth. Compensation of soft tissue can also be determined by using the CT scan, or it can be established by measuring the soft tissue depth with a periodontal probe following anesthesia. In this case, the initial implant was inserted to a torque of over 50 Newton centimeters, which indicates outstanding primary stability of the implant. It's absolutely critical, however, that the implant be stable after placement. There must be no mobility. As the implant bottoms out, the bone is condensed at the apex by the threads and at the crest by the mini threads at the bottom of the tapered collar. Once the implant was placed, an additional few turns were given to condense the bone at the tip and wedge the cortical threads into the cortical bone, creating this mechanical lock at the top and bottom of the implants. Figures 30 and 31 demonstrate the placement of the first implant in proper position intraorally and radiographically. Subsequent implants were placed using the same protocol. We also want to try to parallel these implants, but again, the direction and the placement of the implants was predetermined using the CT scanning software. 1, 2, 3, 4 of the implants are placed. Figure 49 shows the occlusal view of the implants following the arch. Figure 51 demonstrates a facial view of the O-balls intraorally. Next, the patient's existing mandibular complete denture was relieved extensively at chairside, and a soft reline material, such as Kosoft, was placed to stabilize the denture. You can see in figure 52, I use a little indelible marker to actually mark the inside of the denture and relieve that area extensively. Figure 55 shows the use of the Kosoft material. Figure 56 shows the placement of the implants in the soft reline material. Following the stabilization over these implants, the patient experienced immediate improvement of the retention and stability of her mandibular denture. She had minimal discomfort following placement of the conditioning material, and after integration progresses, a new implant-retained mandibular overdenture using the conventional O-rings will be used to create the final proper retention, stability, and dramatically improve quality of life. The final figures demonstrate the post-operative CT scan as compared to the virtual plan, and you can see that they are identical. We were actually able to virtually place the implants, give us proper direction. Once we're completed with this case, with the new O-ring connected mandibular denture, this patient is really going to have a dramatic improvement in her function.